So let's move on to the final case, case 4. This is a patient with stage 4 adenocarcinoma without a genetic driver. It's probably the most common case that at least I see and you see. This is a 68-year-old Caucasian male who is presenting to the emergency room with severe chest pain and dyspnea. He has a history of hypertension and osteoarthritis. He's a former smoker, 20 pack years. He has moderate alcohol use. He's still active and plays golf. His physical exam is noted for generalized weakness and pallor, and his breath sounds are reduced significantly at the left lung base. Has a chest x-ray that shows a very large pleural effusion on the left and a left-sided mass. It's a CT of the chest and abdomen that reveals a 9-centimeter, very large spiculated mass in the left lower lobe and a pleural effusion in the left hemithorax and a right adrenal metastases. The PET scan basically confirms what's seen on the CAT scan, as well as some disease in the lining of the pleura and also some additional liver lesions. And the MRI shows 2 solitary brain mets, 1 centimeter each, with limited edema. He has a thoracotomy and drains almost 2 liters of blood. We can maybe talk about whether that was the optimal approach in this case. And then also has a biopsy of the lung mass showing a poorly differentiated adenocarcinoma of the lung. He has next generation sequencing testing done, and he's negative for EGFR, ALK, BRAF, ALK, HER2, MET, and ROS. The PDL1 is less than 5% or 5%. So so we've got here a patient stage 4, symptomatic, pleural effusion. Good opportunity to engage the surgeon and the pulmonologist here on optimal ways to manage the pleural effusion, and then also get the pathologist's input here. Lonnie, walk us through your management for pleural effusions. I mean, it's a very common thing in these lung cancer patients, how you optimize that and what you do.
Sure. So I think the issue here is, as you suggest, diagnosis and palliation, right? And the nice thing about pleural disease is those 2 things often go hand in hand. So achieving a minimally invasive approach, I think, is warranted. So I agree the choice of thoracotomy, I'm not quite sure about, but I think a simple start of a thoracentesis where you can potentially alleviate symptoms and provide typically ample tissue for a diagnosis would be a great first step. And then we kind of take each patient step by step and see, do they respond from a symptomatic benefit from having pleural drainage? And if they do, what's the next step? Or indwelling pleural catheter is appropriate, or pleurodesis an option? And so it kind of goes hand in hand with the initial interventions.
Okay, I'm gonna push you a little further. So let's say this patient's fast forward, you've drained the fluid twice. Your threshold to either do a Pleurex, or should this patient see the surgeon and do a VATS pleurodesis?
Yeah, so it's a little complicated, and it really is patient specific, because the early factors are, does the patient derive benefit from symptomatic benefit from pleural drainage? If they don't, there's not really a great indication or reason behind more invasive procedures. Most do, and I think then it's how quickly is the recurrence rate. So sometimes recurrent thoracenteses are not unreasonable. From our standpoint, the care has really migrated towards indwelling pleural catheters or tunnel pleural catheters. They're an outpatient procedure. They're minimally invasive. Patients get to go home same day and control the amount of drainage and really derive symptomatic benefit. And in well over 50% of patients, they achieve pleurodesis just from the catheters themselves. If those fail, then I think Mickey's role is certainly an important one.
Mickey, your thoughts on?
I agree wholeheartedly. Only a few reasons I think I would perform VATS. I don't know why they did a thoracotomy here, but certainly a minimally invasive approach. If more tissue is needed, I think that's another reason we'll go in with the scope. But outside of that, we don't typically decorticate malignant pleural effusions. And any surgery that I do, I think you're going to delay the onstart of what they really need, right? And that's systemic treatment. So I think the Pleurex, you can go just blow right through. They can get chemo throughout the Pleurex insertion as opposed to a VATS procedure, which may delay it. But certainly if they need more tissue, I'd do VATS. If they were a younger, very good performance status person, I probably would lean maybe to a VATS pleurodesis. But you have to remember, 25 to 30% of those patients may have trapped lungs. So the pleurodesis isn't going to work, so you're going to end up putting a pleurix anyway. So most of the time, again, very patient-specific, as Lonnie had said, but a younger person with a great performance status who doesn't want a long-term catheter because they get infected, I'm sure we've all seen that, and that's really a death sentence for a lot of our patients, or more tissue.
Yeah, it's like everything else in lung cancer. It's an individualized treatment approach, I think, based on patient preference, performance status, and a lot of other factors. I don't know if there's any hard and fast rules here, but it's good to get the input of both of you. Sam, the pleural fluid and how successful we are getting mutational analysis off of pleural fluid. I just had a case a couple of weeks ago, a patient who had her similar to this, presented large pleural effusion, and they were able to get off 2 liters or 1.5 liters, spin it down, get something that they can put in paraffin, and I call my pathologist a lot, by the way, and say, do you have enough? Do we need more? The patient doesn't want another biopsy. We'd really like to get the information. What's the comfortability with getting the molecular testing off pleural fluid?
So DNA is DNA, and if you've got malignant cells there, it depends on, has the lab that's going to do the testing validated against a cytology sample, that's been spun down and put into formalin. We like cytology samples. Often the DNA is better preserved, and because of those cells. You do need to look at the ratio of your tumor cells to your non-tumor cells. Often there are some very reactive mesothelial cells, a lot of inflammatory cells in these specimens. So that needs to be looked at to make sure you don't get a false negative by whatever methodology you're going to use. They can work great, and like I said, we like them.
Yeah, I think they can. I think that the message is to try to aim for a biopsy, either a core needle or an FNA. But there are times, and we try not to use them for molecular testing because sometimes we just come up short with the information we need off of them. And some highly cellular fluid, as you mentioned, if it's highly cellular and got a lot of cancer in there, then we can get the information we need. But I would say that the attempt should be made to get a core needle or an FNA. But as one-off, sometimes you can, as you said, you can get enough to make the diagnosis, do PD-L1, and do NGS.
Yeah, in fact, we had one of our first ALK cases that was positive, was a pleural effusion that was just packed with malignant cells. So, in some cases, it's actually the better sample. So I think, again, it just requires that multidisciplinary discussion. What do we have with the pathologist providing the input on what our options are with what we've got?